I have the pleasure of introducing Dr. John Brownstein. He's the Vice President, Chief Innovation Officer at Boston Children's Hospital, who's been doing absolutely fantastic work at integrating AI in all kinds of ways at Boston Children's. John and I did a fireside chat that hopefully has a link on the EAI website that you can access, where he goes into a lot of detail about some of those things, but I'm sure he's going to highlight some of those today as well.
Thanks so much. All right. Great to be here. It's a real honor to be invited to this amazing conference. I'm actually not going to really talk about any of that exciting stuff. I'm going to talk actually about a lot of boring stuff. So Gene, I'm happy you brought up the idea of the boring stuff in healthcare. We heard some amazing talks today, and also, we heard from healthcare execs that were really setting the stage for what I'm going to talk about today, which is how do you really bring AI into a health system, and why do we even want to do it? Well, there's an imperative that we have right now. Healthcare costs, as we just heard, driving up. The cost of taking care of a patient, driving up. The cost of labor, driving up. Our healthcare volumes are down. Our margins are down. We have a healthcare crisis of being able to support our health systems broadly in this country. And so there are many solutions, I'm sure many exist here, but AI represents at least one possible area where we can invest to think about ways to reduce our costs, reduce the burden that we place on our providers, and up the patient experience. Clearly, we already know what the value proposition is for healthcare and AI, right? The idea of improving productivity, the idea of reducing burnout, the idea of improving the patient experience through new tools and new ways to continuously engage with patients. Obviously, there's this view that clinical outcomes can be improved because now we have a co-pilot sidekick alongside every clinician. And of course, and I actually reported to the CFO, cost reduction is a big one. Where can we bring in the tools that will support the reduction of the massive amount of cost that it takes to take care of our patients? So when I talk about the boring things of healthcare, and hopefully you won't be bored in this talk, but really, what do we need to do to upskill an entire institution to take advantage of these tools to reduce the costs that we are spending taking care of our patients? And so when you talk about the mundane things, yes, there is the visionary areas that we want to talk about, but the opportunities around translation and producing culturally relevant materials, the ability to help with in-basket messaging for a provider to support them in the sort of onslaught in messaging they get from their patients, the ability to document clinical encounters. The list of pain points that we get from within our organization are substantial. They may not be the sexiest of areas, but they are ones that are fundamentally drowning us in costs and in burden. And so from this talk, I'm going to talk to you a little bit about what we're doing to get to a point where we can take advantage of these tools, the amazing innovations that we're, of course, talking about. And of course, many of you here are building some of those tools. So why do we want to do it? Of course, there's a financial ROI. We build in these tools. We will reduce the numbers of FTEs that it will take to behind the scenes take care of our patients. We want to, of course, steward AI in an appropriate way. It is the Wild West right now in our hospital. I'm sure organizations across the board that are using these tools and using them in slightly dangerous ways, putting patient data into tools that they should not be putting patient data in. Of course, bottom line, we want to demonstrate quality of care and improve experience. Those are things that are fundamental, and those should be always things that we strive for. And as an academic medical institution, of course, we want to push the boundaries of innovation. So how do we do this? Well, the first thing is we have to build capacity. We have to get everybody at the hospital on board with the ability to use these tools effectively. We have to align with the regulatory landscape, so we have to be in sync, and this is changing dramatically. We have to have a strategy and governance that is thinking about what tools can be appropriately used in our institution. We have to build a roadmap, and of course we have to launch and actually measure the impact of the tools that we're putting in. Of course, it's really nice to see a lot of tools and a panacea of incredible innovations, but if we're not measuring the impact, then of course it's all for naught. Okay, so from a capacity building side, this is probably maybe more in our organization, but I'm wondering if others feel this way. Gen AI, of course, is a beachhead. People are excited. They are so pumped to use these tools. They come to us and they have an idea, and I'm like, that could just be written by a two-line Python script. You don't need generative AI. So we have to educate our organization about what tools are appropriate, and there's a wide range. And Gen AI is one of those tools, but basic rule-based automation is absolutely effective in so much of the work that we're doing within our organization. So part of it is just literacy, education. And so we're building that underlying apparatus that is going department to department within our organization, whether it's clinical departments or administrative departments, doing road shows, explaining what they need to have to effectively use these tools safely and securely, and really engage the organization in broad-scale adoption. So how do we do that? Well, we were launched one of the first hospital-wide GPTs. So everybody at Boston Children's now has access to a HIPAA-compliant, secure GPT that feels and looks like what they would do on the consumer site, but it's HIPAA-compliant, protected. They can put confidential information, and right out of the gate, over 10% of our employee populations are using these tools. Now, of course, there's more sort of in-depth use of these tools, so we give API access to the HIPAA-compliant OpenAI tool, as well as creating tools for non-developers. There are plenty of ways to create non-developer level tools that can create chatbots that essentially allow any department to effectively use these efforts. Ultimately, we don't have enough people on our own team to go department to department and actually build these tools, so we're trying to democratize as much the access to these kind of information. We have built a team, and in fact, what we're seeing more and more, and we're one now of many organizations now have hired a prompt engineer. That is sort of a title that didn't exist within our HR lexicon. We had to create a whole new JD and advertise for it. There weren't that many people that had prompt engineering experience plus a medical degree. We somehow found one of those unicorns but it's beyond just a prompt engineer. We have a whole team of UI, UX engineers that are helping build and prototype and launch these tools within our organization. There is a lot of effort on the policy side, and so as an organization, we have to align with what's happening on the market side. We heard earlier today from John Hlomka about the Coalition for Health AI. There's efforts out of Epic and out of OpenAI. The White House has a whole initiative, promises around the effective and transparent and responsible use of AI. So as an organization, we have to be lock in step with each one of these initiatives, keep on making sure that we're using these tools responsibly and exactly how other organizations are thinking about them as well. We're also having to spend a lot of time researching. We're trying to understand what our patient populations are willing to accept. We do a lot of surveying and research to understand, is a parent willing to bring their child in and actually have the AI co-pilot next to them, supporting whether it's clinical documentation or medical decision-making. We're also trying to think about very clearly, what does it take to actually implement AI effectively in an organization? The Coalition for Health AI has spent a lot of time thinking about these sort of health assurance labs. You may have heard of these, where there are organizations, John Hlomka is part of that, where they will effectively test an AI algorithm in a particular patient population. The problem is one patient population at the Mayo Clinic is not going to look like a patient population here in Boston. And so we effectively have to create implementation centers at every health system to essentially make sure that we're testing and training on the appropriate data, so we are not necessarily using algorithms that were trained for a completely different population. I think that's pretty clear to everyone here. The challenge we also have is there is broad interest in AI across the organization, but it's not one size fits all. We have massive enterprise efforts. We need to fix our capacity constraints. We need to think about data monetization. That's an enterprise effort, but what about the physician who wants to build a particular workflow for their own particular problem? We don't want to push a particular physician through this enterprise lens and then suffocate them from actually being able to build their own tools. So we have these two different levels of development that allow us to essentially meet all the demand that exists within our organization. Regardless if it's small scale or large scale AI, and I'll talk about examples across of that, we have to think about equity, and we've talked about this already today. But from a team perspective and a governance perspective, we've actually had to build a whole component within our strategy efforts that is thinking about the diversity within the builds and the teams that are utilizing these models, algorithmic fairness and inclusion, so making sure that we're not only monitoring that and understanding that at day one at the launch of that model, but doing that over time because we know these models drift. We have to think about accountability and training, understanding that every physician who's using these tools, they're not using them, in an automatic way. They are essentially being used to support the clinician, not being used in a bubble. And of course, making sure that we're aligning with legislation, privacy, and safety measures. So this might be too granular, but I hear there's a lot of startups in this room, and so it's important to understand what a hospital is trying to think about when we're thinking about if you engage with us and try to think about how you want to work in our accelerator at Boston Children's. Well, first of all, we are going to look for our existing partners. We have Epic as our electronic medical record. We have big partnerships. We will look to see if those partners actually have those tools. And unfortunately, sometimes those tools are coming a year out, but that will define our sort of decision whether to work with them. that doesn't exist, we'll look to buy in the market. So that might be some of the products you're developing here. I have 2 minutes? I just started. Didn't I just start? Can't be 2 minutes. There's no way. All right. Well, then, okay. Well, then we're going to just go really fast. 2 minutes. So what I want to talk about, and maybe I'm going to just give me a few more minutes, is that we've been on this AI journey now for over a decade. And there's a lot of work that's happened in this organization that was well beyond this sort of generative AI phase. We've been thinking about predictive and algorithmic models, machine learning efforts for a decade. So one of those examples is a tool that helps to define and predict whether a patient will be admitted to the hospital after being seen in the emergency department. So very simple machine learning tool. Patient comes in with symptoms, they're looked at against historical data, and then immediately we decide whether they need a bed. This helps with capacity constraints and supports us in sort of effective patient flow and patient experience. I did want to touch on infectious disease because, of course, the area of disease surveillance, and it's one that I've worked very closely with Dr. Brilliant and Sam Scarpino over many years, is information that has supported us in public health surveillance. But the reality is, how do you connect that to actual decision making in the hospital? So we had the triple-demic a couple of years ago, RSV, COVID, and flu. We had a challenge in capacity. We did not know whether we could have elective procedures for our patients. We didn't know what the capacity needs would be within the hospital. So with modeling and machine learning and integrating this external data, we built effective models that essentially predicted to the day when we might be able to open up beds for elective procedures. So I'm going to skip through. Okay, all right. So I'm going to skip through here. Wow, I don't know how that happened. Okay. You can take a breath. I'll take a sip of water. All right. I'll just close with just a couple examples in fine-tuning LLMs, because of course, there's a lot of work in predictive modeling. There's a lot of work that has happened over the last decade in voice and NLP, but there's real significant opportunities for us to fully appreciate how to take these large language models and bring them into healthcare. Even the most, and I was going to talk about boring examples, a boring example is our invoicing department. We get 15,000 emails per month of vendors trying to get paid just from the hospital. So some automation and some generative AI, all of a sudden we can reduce by, and maybe reducing FTEs is a dangerous topic to mention, but the ability to actually reduce the overall cost of providing care within our organization, just from a basic automation algorithm, tells you that there are boring efforts to be done within an organization to go beyond just the pie in the sky diagnostic areas. There are plenty of other examples. I'm running out of time, so I won't get into them, but just the idea that you could take all the content from the hospital, build a tool that allows you to essentially understand policies within the organizations, or whether it's for learning purposes. So the idea that you can turn the LLM into a med tutor that goes and helps you through a differential diagnosis. These are the kinds of examples that can be done. Again, not sort of the pie in the sky areas, but the ones that can be so super supportive to the organization. Finally, I'll just mention, we are trying to democratize access. This is a tool called Bot Builder, which essentially we can then deploy to any department within an organization to build a tool that then supports their needs, whether it's in the eating disorder clinic or the cardiac ICU or taking patient histories in the emergency department. All of these use cases are tools that now our own organization can build against. There's plenty else that we can talk about, but we'll leave it for opening up for questions. And thanks so much. How did I go through this?
We have a few minutes for questions. Just raise your hand.
Hello. Oh, great talk. I'm over here.
Oh, yeah.
Thanks, Jens Ruder from the Jackson Lab. I have one question. You mentioned many examples of where you're using AI tools sort of in clinical care or in workflows. Are you also evaluating the effectiveness prospectively, and how are you doing that?
Yeah, so everything that we do is prospectively measured. So that's a big part of so any deployment that we have around AI is essentially analyzed for the impact, whether that's the impact in terms of numbers of hours saved, or of course not every algorithm has that sort of feature, but that's a big part of our tracking, because that's actually part of our enterprise metrics of showing the value of these tools. So if we can't track it, then we're not deploying it.
And are you seeing these improvements that you were expecting most of the time? Or?
Yeah, I mean, listen, I think there is a double-edged sword because, of course, there's costs in deploying these tools. We've seen them go off the rails. We've seen situations where we've built bots that are not necessarily providing the value that we would have wanted, and in those cases, we would pivot or remove them. But overall, like in some of these very back-end tasks or tasks that we've deployed in, say, HR, revenue, finance, all of those essentially are showing incredible value. So it means that people are gaining time back in their day-to-day work, and it ultimately means that we don't have to keep growing the administrative side of the organization at the same speed that we were.
Quick question. I have a client that's a hospital group, and there's severe distrust, especially since burnout during COVID and frontline workers just feeling that way.
Yeah.
Do you find it all, it's also a union hospital, so they are predisposed to just not trusting upper management. Do you find that AI increases distrust amongst the workforce because of the uncertainty of what it means to them?
It's a great question. We're not finding that. In fact, there is obviously, this is why we're dipping our toes into the water. We're going for small wins, low risk use cases, and they're just providing tremendous value across the organization. We are not, we heard earlier today, and Dr. Burley mentioned hallucinations, and those sort of areas which erode trust. We are not picking those as our use cases, our areas that we're focused on. So clearly, the further we go, we're going to have to address this issue. But ultimately, what's happening is we're just seeing a ton of enthusiasm around building these tools into day-to-day practice.
Hi, so I have a lot of questions. I'm Barina Hall. A couple of things caught my interest. Well, everything was interesting, but in particular,
the other half of it was good too.
Actually, would there a way to get your slides by chance?
Sure. Yeah.
Perfect. Health literacy was one of the things you mentioned, as well as you talked a bit about prompt engineering. So the quality of the output often depends on the quality of the prompt, and if it's patient-facing, there's going to be a range of language. And so there's some research showing that it's not folks in this room who go to ChatGPT to ask their questions, but it's actually the less literate patient type.
Yeah.
Are you doing work in that area? How are you thinking about that? How do you think about prompt engineering for the range of digital literacy and health literacy and literacy for like the digital divide?
Yeah, I think it's a great question. I mean, there's obviously, we're thinking of this right now from a healthcare perspective. We're not putting this in front of patients yet. I mean, that will come. We're obviously thinking about the opportunities around LLMs actually to support better sort of healthcare communication. One of the things I didn't talk about today was just around our translation efforts. And I'm sure David will have some conversation about some of the challenges he sees with AI in the panel. But we're actually implementing AI to support translation, support meeting people where they are. And so far, the initial analyses that we've done have shown that these tools are actually improving medical communication and supporting our ability to provide more customized discharge notes. So in those particular examples, they're highly valuable. When we start pushing this out directly to patients, I agree that is going to be a challenge, right? And I don't think we're going to be asking patients to write their own prompts or interpret sort of the output of these tools. This is all going to be about sort of supporting the clinicians in doing their day-to-day jobs. But I do think those tools are out there, right? I mean, and I think, especially if you look at the AI therapy tools, those are coming, and I think there is a very strong chance that those will further divide, even though these tools are meant to sort of democratize access in ways because of the shortage of healthcare access.
Thank you, John.
Okay, thank you.